Welcome to Pathology Central Race in Medicine. In this video, we're going to take a familiar mnemonic, which is used in teaching the differential diagnosis to medical students. We're going to do a small tweak and hope that by doing so, we will be able to be aware of when race-based medicine is creeping into our differential diagnosis. So all of you should be familiar with this particular mnemonic, VINDICATE, which is used for medical students to develop a systematic approach to the differential diagnosis so that they don't leap to the immediate conclusion when they see someone present with a cough and think, it must be pneumonia. Could it perhaps be something due to a neoplasm, which is occluding a bronchus, for example? Don't leap to conclusions, work through systematically. So begin thinking vascular. Could this be pulmonary embolism? Infectious? Could this be some sort of bacterial pneumonia? Inflammation? Could this be an autoimmune disease? So we teach our medical students to think about things systematically. Now, as a pathologist, I don't use this particular mnemonic. What I do is I have a little checklist for myself. And whenever I think something looks malignant, I always stop and I say, is there something benign that this could be that I'm not thinking of? And if I think something is benign, I stop and I say, is there something malignant this could be that I'm not thinking of? So that is my checklist when I get to the end and I'm ready to make a diagnosis. So what we're recommending is that as a medical student, as a diagnosing physician, once you make it all the way down, you've got a robust, strong differential diagnosis and you're ready to start ordering your laboratory tests to confirm that diagnosis, you stop and you think, am I missing something? Is there something I'm not thinking of because I've made an assumption that is rooted in race-based medicine, that I am making assumptions based on how I perceive this patient's socially defined race or ethnicity? Am I making assumptions that don't account for disparities based on where a person lives, what their income may be, whether they are near a Superfund site or whether there's lead in the building where they live, these disparities that affect our populations? So stop and think and then go through one more time. Now, when I think about using this sort of checklist, right, to put that patient into that individual's context, right? Look at the patient and see where is that patient in their particular context. I think a great example of this for us is cystic fibrosis. Because cystic fibrosis is a disease that is so strongly correlated with European descent. So here are two examples from the literature, one from Robbins' 10th edition of Basic Pathology and one from Up to Date. Just as an aside, the term Caucasians is outdated and should no longer be used. Here are two references that will go into the details of why that is. But the gist of these two quotes is that cystic fibrosis is much more common in individuals of European descent. So if you are looking at an individual of European descent and you hear hoofbeats, you'll be thinking horses, right? Because this is a common disease in that population, relatively common. It is not as common in other populations. So to highlight that a little bit more clearly, these are the up-to-date data once more, looking at prevalence by population. And then this is looking at the cystic fibrosis patient registry in the United States. And you could very easily say, well, 94% of patients in the United States with cystic fibrosis are of European descent. So therefore, if I have someone who's African American who's presenting with recurrent colds or failure to thrive, pneumonia, that this should be very low on my differential diagnosis because it's not common in that particular population. But these data also show you just because something is uncommon in a population does not mean it does not occur in that population. So if you have a patient that's presenting with those suspicious symptoms, stop, think about diverse and disparate populations and see, is there something here that I need to be thinking about? So let's look at two examples from the literature of cystic fibrosis. Here we have an article from the Journal of the American Medical Association from 2021, tackling the misconception that cystic fibrosis is a white people's disease. This is because we are missing this diagnosis in other populations. This particular individual shown here on the right is an African American man who was not diagnosed with cystic fibrosis until he was 54 years old. We also know, and you can see more of this on my video on cystic fibrosis, that the newborn screening tests are not as accurate in examining non-European alleles for cystic fibrosis. We have a second example here, also from the literature, about a young girl who was not diagnosed with cystic fibrosis until she was 8 years old. And only then when the physician literally could not see the color of her skin, could only see the chest x-ray and said, hey, who's a kid with cystic fibrosis? So would it make a difference if, as an individual is going through and making that differential diagnosis, if by coming to the very end they said, am I making an assumption about how this patient is presenting and linking it to socially defined race, how I perceive their race to be, even what they state their race to be? Because as I said, just because something is uncommon in a particularly socially defined race does not mean it does not occur there. So please keep that in mind. This is a new idea that we've been workshopping around here at Duke. I'd like to thank Dr. Kenny Raley in particular. He's the co-director of our course, Culture Determinants of Health and Health Disparities, for helping me to frame this, as well as these other physicians who are much more involved in differential diagnosis than I. Please do put comments down below. Let me know how this is working for you, how else we can tweak this. Let's put it together. Let's work on addressing race-based medicine. Thank you very much.